Administrative Living. I'm a Federal Program Officer for both the National Family Caregiver Support Program and the Lifespan Respite Care Program, and I'm pleased to welcome you to this webinar. This webinar is part of the Older Americans Behavioral Health Technical Assistance Center. There supports an important partnership between Substance Abuse and Mental Health Services Administration and Administration on Aging to provide issue briefs, webinars, regional policy academies for states focused on alcohol and prescription drug misuse and abuse, anxiety and depression, as well as the important topic that we discussed today, the behavioral health issues related to family caregiving. Next slide, please. We have objectives that we want to achieve as a result of this webinar. Specifically, we want to go over some of what we know of caregiving in the U.S., the numbers, who caregivers are, what they do, the impact of family caregiving, and what is known about caregivers caring for persons with mental illness. We also want to explore some of the strategies for reaching and engaging caregivers, as well as assessing and referring them to mental health services. Also going to be discussing some of the evidence-based interventions that impact caregiver issues such as depression, anxiety, anger, coping, and problem solving. We're also going to be presenting you with some practical approaches for working with caregivers, and at the very end we'll explore some resources such as the National Family Caregiver Support Program, the American Psychological Association's Caregiver Briefcase, and other partnership opportunities that you may wish to explore. This webinar will be recorded, and the recording and the slides and a list of the resources of caregiving will be provided to all who registered for this webinar. Continuing education credits are not being offered for this webinar. At the end, we hope to have approximately 15 minutes for a Q&A session. We will address questions as they come in. If you have questions, please type them into the chat box at the upper part of your screen. Next slide. To the meat of today's discussion, I want to introduce our speakers for today's webinar. In addition to myself, we're going to feature 3 additional speakers. After presentation, we'll hear from Barry Jacobs. Dr. Jacobs is a clinical psychologist, family therapist, and author of the book Emotional Survival Guide for Caregivers, looking at yourself and your family while helping an aging parent. As a physician, he specializes in helping families cope with serious and chronic medical illnesses. As an educator, he works as the Director of Behavioral Health Sciences for the Crozer Keystone Family Medicine Residency Program in Springfield, Pennsylvania. He has had adjunct faculty positions with Temple University School of Medicine, UPenn School of Nursing, and the Institute for Clinical Psychology of Widener University. Dr. Jacobs his doctorate in clinical psychology from Hahnemann Widener Universities. Dr. Jacobs we followed David Kuhn. Dr. Kuhn is the Associate Vice Provost, Health Solutions, and Professor in the College of Nursing and Health Innovation at Arizona State University. His research interests include the design, evaluation, and translation of effective psychosocial interventions for midlife and older adults facing chronic illness such as Alzheimer's disease, cancer, HIV/AIDS, depression, and their family caregivers. He received his doctorate in counseling psychology from Stanford University. The third speaker is Sarah Hahn-Qualls. Dr. Hahn-Qualls is the Kramer Family Professor of Aging Studies and Professor of Psychology and Director of the Gerontology Center at the University of Colorado in Colorado Springs. She is a practicing clinical psychologist who helped establish the CU Aging Center in Colorado Springs, which provides mental health services for older adults. She has published 6 books on mental health and aging topics. Her research focuses on family development and clinical interventions for later life families, innovative approaches to senior housing and applied technology, interventions to improve the well-being of older adults. He has served on Dr. Goodhart's 2011 Presidential Task Force on Caregiving that produced the tool for psychologists called the APA Caregiver Briefcase that she'll be talking about today. She received her doctorate from the Pennsylvania State University. Slide. Again, I want to thank the American Psychological Association for their assistance in developing this webinar. Next, please. Now, before we delve into the specifics of today's topic, I wanted to spend a few minutes getting everyone on the same page with respect to the magnitude of family caregiving in the U.S. And some of the unique needs and concerns of family caregivers who provide care for persons with mental illness or substance abuse issues. Family caregiving is a very prevalent issue in this country as it is worldwide. The National Alliance for Caregiving studies the prevalence of family caregiving and the types of challenges these individuals face. Consider the totality of family caregiving in the U.S. The National Alliance found that there were approximately 65.7 million people in the U.S. who were reporting a family caregiver in 2009 to adults and children with special needs. We know that family caregiving is an important part of our long-term services and support system here in the U.S. Estimated that family caregivers provide something like 80% of the long-term services in the U.S. And we also know that what they do and what they contribute has tremendous monetary value, and that has been estimated at anywhere around $450 billion. When we begin breaking down the caregivers into certain demographic groups, we also know that there are approximately 43.5 million caregivers caring for someone 50 years of age and older, and approximately 14.9 million who care for someone with Alzheimer's disease or another dementia. What's probably very obvious is the trend that's likely to continue in family caregiving. As our population ages, it's likely that we're going to see increasing numbers of caregivers in family caregiving situations. These numbers are staggering, and I think they demonstrate the breadth of the issue we're facing. What is even more significant is that as our population ages and we put greater and greater focus on community living, we're going to see, I believe, a greater number of family caregivers. Next slide, please. So there are a lot of caregivers, but who are they? We know also that family caregiving is not strictly an aging issue. Quite contrary, it's a lifespan issue. We know that it isn't necessarily just a male or female issue. What we know, however, is that there's a fairly typical profile of who the family caregiver is. We in the research that's been done by the National Alliance that that caregivers are predominantly female, that they average about age 48. We're also seeing increasing numbers of men becoming family caregivers or stepping into that role. We're also seeing that there are sandwich generations where you have individuals who are caring for aging parents as well as children. We're also seeing increasing numbers of grandparent and kinship caregivers, grandparents and other relatives who step in to raise young children. And of course, we're seeing an increase in the number of parents who become caregivers to their children or other wounded warriors who come back from the conflicts overseas. Next slide, please. We know that there are a lot of caregivers, and we know quite a bit about who they are and what they do. And I think it's fairly easy to say that most caregivers will agree that they'll do whatever it takes to care for their loved one at home. We family caregivers come all from walks of life, and that they care for individuals across the age and disability spectrum. And we also know that the caregiving tasks that they do vary a great deal in terms of complexity and the levels of skill required. The types of things that family caregivers do for their care recipients can range from basic transportation to doctors, grocery shopping, paying, to the more complex tasks like medication management, wound care, and other complex medical care procedures. We also know that family caregivers spend a great deal of time doing what they do, but on average, it's been found that they spend about 20.4 hours per week providing that care. Next slide. Now, while family caregivers report getting a good deal of satisfaction out of the work that they do, that satisfaction also comes at a price. And the price is often the caregiver's own physical, emotional, social, and financial well-being. The impact on the physical and emotional health to family caregivers can vary greatly from individual to individual and from situation to situation. Family caregivers can also experience different types of impact and varying degrees. One thing to note is that studies have shown that family caregivers who have been providing care for 5 years or longer typically report their health as either fair to poor. While not specifically a focus of our discussion today, caregivers who are in high burden social or emotional situations are also at risk themselves for problematic alcohol use and abuse. Caregiving, we know, can be highly stressful. And it's interesting but not altogether surprising to note that women are more likely than men to report high stress due to caregiving. It's probably because there typically are more women, and they typically tend to take on the more complex tasks in caregiving situations. For the purpose of our discussion today, it's also interesting to note that caregivers of those with emotional and mental health problems are more likely than their counterparts dealing with other issues to report a decline in their health. Next slide. As we begin to focus our discussion today on family caregivers as partners and clients of behavioral health services, I wanted to spend just a moment talking about the magnitude of the issue of mental health here in the U.S. It's been estimated that there are approximately 26.3% of adults 18 and over have been diagnosed with a mental health disability, and 6% of those adults have a serious mental illness. Mental illness is also known to be a leading cause of disability among those ages 15 to 44. We all know that mental illness impacts many areas of individuals and family life. It impacts health, interpersonal relationships, marriages, employment, and family life in general. And if we had to put a dollar amount on it, studies have shown that mental illness can cost approximately $183 billion in lost wages. Please. To see a continued trend upwards in the overall number of family caregivers as it continues, it's probably not too far-fetched. I assume that we will likely see the number of situations in which family caregivers are caring for someone with a mental illness increasing as well. Some may have to do with the very positive reality that as we move further away from institutional settings as the norm and promoting more community-based options for persons. Indeed, that has been the case for more than 60 years, and I think we can all agree that that's been a very positive trend. However, we more fully embrace the concepts of community-based long-term care and services and supports and strive for ever greater integration of persons of all ages with disabilities into our communities. We must acknowledge the fact that in order to do this effectively, more family members will likely be stepping in to fill in the gaps and provide help where needed. The National Alliance for Caregiving, in their most recent 2009 study of family caregivers, found that approximately 32% of all family caregivers provide care for someone with emotional or mental health concerns. And it is also likely that many individuals will require multiple family members to become involved in their care. Depending on that relationship, different family members will likely have different support needs as family caregivers. So, for example, the spouse of someone with a mental health or substance abuse disorder interacts and reacts and is impacted by the situation may be different from a child, a friend, or another relative is impacted or deals with the situation at hand. Next slide, please. Care burden, I want to talk about that for a moment because that's typically the term you hear frequently as a way to describe the level of disruption that's caused in the lives of family members by the care recipient's condition. And we're focusing more and more on how we attempt to quantify or measure the level of burden experienced by family caregivers and then address those needs in an effort to alleviate that burden. It was shown that burden can be both objective and subjective. And how we effectively support caregivers and those interventions that we employ can be determined by whether a caregiver's burden is more objective or subjective, or perhaps a combination of both. When about objective burden, it's more about the the external influences, the economic issues, the caregiver health impacts. Where when we talk about the subjective, it typically refers to the amount of stress, emotional, psychological impacts on the family caregiver. Individuals with mental illness or substance abuse issues do have specific needs and concerns as they grapple with the challenges of providing that care. Most notable among these concerns is typically accessing specialty services or making use of other home and community-based services like respite care. Because most family members not typically and adequately prepared to deal with a loved one's mental illness, the stress alone of such a situation can make it especially difficult to manage the care recipient's symptoms or even to follow their treatment plan if there is one. That if a caregiver is stressed, the care recipient has greater difficulty even following their own treatment plan. And being family caregivers, we know, is often difficult even in the best of circumstances. However, given the fact that mental illness and substance abuse issues can be especially unpredictable, specific interventions and therapeutic services are all necessary to caregiver stress and enable them to better manage their situation. The next several presenters will walk us through how to better assess, engage, and support family caregivers through their experience. I turn the presentation over to Dr. Jacobs. Barry?
Yes, Greg, thank you very much. It's really a pleasure to be here. I look forward to hearing ideas with you. Next slide, please. What I'm going to be talking about a little bit, one, how do we get caregivers actually to use the services that we have to offer them? How do we get them in the door? Because as you likely know, there are many folks who are providing caregiving who do not identify themselves as caregivers and therefore do not access caregiver support services. So I have a few ideas along those lines. Once we get them in through the door, we need to figure out how to assess them, specifically how well those caregivers are coping. We need to help them get help for themselves. In my experience, many family caregivers are reluctant to opt for or even accept support when it's offered. And finally, I'd like to talk a little bit about when and how to refer a family caregiver to a mental health specialist. Next slide, please. So I'll tell you a little bit about a psychotherapy patient who came to me not long ago. His name was Don. He's a 56-year-old African-American man whose doctors sent to see me for anxiety and career burnout. And Don's initial complaint to me was, I'm an anxious wreck at work. The story that Don told is that he's worked in the same job in a bank in a very high-pressured position for over 2 days. But in talking with him, I got the impression that he hadn't been stressed out throughout the years that he's been working until very recently. And at that point, he began to tell me that he finds himself thinking while at work of his mother, who has severe COPD as well as depression, and spends most of the day alone in her home. And so preoccupied with his mother that he would calling her 5 times a day, and then as soon as he left work, would her house and spend some time with her before he went home to his own house. Next, please. Next, thank you. So, what I found with Don is that he was emblematic of a lot of folks who are out there doing caregiving, who may not be so accepting of the help that we have to offer. So, one thing he said to me is that he was embarrassed that he felt so anxious when, in fact, it was his mother who was suffering because of all medical conditions. We talked a little bit more about his situation as a family caregiver. He really, to me, I don't know what family caregiving is. I'm not a caregiver. I'm a son. And when I talk with him about possibly calling the area agency on aging in our county to get some support services for himself or for his mother, he had never heard of a AAA and didn't know anything about family caregiver support programs. To make this more complicated, his mother was also very reluctant to accept services because she didn't like the idea of home health aides, or in her mind, strangers coming into her home. And that she didn't want to even be treated for depression because in her mind, the idea of being depressed was in and of itself stigmatizing and really reflected a kind of flaw in her character or even a weakness in her sense of faith. Next slide, please. So, Don is in my office. If during that initial visit I had given him the phone number for AAA or to a caregiver support group, the likelihood is he would not have gone. So the question is, how do we age folks like Don in the process of identifying themselves as caregivers and then seeking support for themselves and for the folks that they are caring for? Next slide, please. I had two ideas along these lines, and these are ideas that, in fact, I've helped put into place in the family caregiver support program in my county in suburban Philadelphia, where I'm on the advisory board of our family caregiver support program. And one is I don't recommend advertising caregiver services, and I don't recommend having community events which talk about caregivers support or caregiver burnout, but instead to have educational sessions which are a little bit more neutral in tone, talking about taking care of an aging parent or education sessions on specific diseases like dementia or COPD or depression, that it's less stigmatizing for caregivers themselves to come to those educational events. And then once you get them through that door, you can then begin to talk with them about family caregiver stressors. Next slide, please. Idea I've had, and I've seen this be successful, is and I come to this idea because I work in a large family medicine practice outside of Philadelphia, is in some way using the power, the prestige of physicians to help give a blessing to services that we have to offer in the social service and mental health fields. And so the National Association of Area Agencies on Aging years ago had put together a program called Making the Link, which was specifically about how AAAs could develop relationships with primary care physicians in their communities. That program is still around, but even without that program, I think it's very important for all of us to let the primary care physicians know who we are, what the services are, because those primary care physicians are in an ideal place in our social service and healthcare systems to get people into our doors. Next, please. So we have them in the door. We have to. The first thing I think we need to do then is to really assess them. And I'd like to just share a number of different resources with you along these lines. The first is there was a task force put together by the Family Caregiver Alliance in 2006. It was chaired by my friend Lynn Friss-Feinberg, who now is at AARP. But that task force that chaired came up with 7 domains that we need to attend to as caregivers. So number one, the context caregiving, what exactly is going on, who's caring for whom. Number 2, what's the caregiver's perception of the care recipient, the care recipient's needs. 3, what are the caregiver's values and preferences, and many of those are shaped by the spirit of the caregiver. 4, what is the well-being of the caregiver? Because as we're going to talk more about this afternoon, many caregivers are suffering because of the caregiving that they're doing. So that the 5, what are some of the specific consequences of caregiving? Number 6, the caregiver's specific skills, abilities, and knowledge, and what are gaps that we may need to have to address in those areas. And number 7, what are some potential resources within agencies or in the communities as a whole to help caregivers? Next, please. Our approach to assessment. Co-presenter today, Sarah Hahn-Qualls, in her book, Caregiver Family Therapy, has a list of questions. I've just selected a few of them, which I think are good questions to begin understanding the experience of the caregivers who we're thinking. So asking them, how would you describe your caregiving experience, or you spend time with friends or in social activities? Begin to get an idea of what the lived experience of these caregivers are. Really gives the best handle on seeing to the degree in which they're serving those roles and the degree in they are feeling burdened by those roles. Slide, please. You may know there are also a number of formal paper and pencil instruments for caregiver assessment. These are available, by the way, in the AP Caregiver briefcase that you heard Greg mention. So a number of them, the most used ones are the Zarat Burden Inventory, Caregiver Assessment Questionnaire, and Perceived Support Scale and Perceived Benefits of Caregiving. Next slide, please. I just wanted to show you a page from the Caregiver briefcase. So this is the page in which there are links to different assessment tools with information about the individual tools, how they can be used. And I think that having a formal assessment tool is a very good idea as part of your assessment protocol. Next slide, please. So, so now we've got them in the door, we've assessed them, and things we need to assess is how likely are they to really take care of themselves, because as you probably know, caregivers are notorious for neglecting their own needs. They may be going to a doctor's office on a twice a month or 3 times a month basis, but they're not going there for their own health care needs, they're going there for their care recipients' needs, and they're neglecting their own health care. And to that point, my patient Don would never have come to see me as a psychologist if his physician hadn't twisted his arm to do so, and if he wasn't really at risk of losing his job. For me to just simply tell Don, or any caregiver for that matter, that taking care of himself will better enable him to care for his loved one, doesn't always do trick in helping that caregiver better take care of himself. As a matter of fact, I have found it's really a very limited effectiveness. Next, please. I've come up with 3 ideas that I've worked with over the years. I just want to share with you very briefly. This is not rocket science. This is really more of how do we grab people's attention and kind of get our point across to help them care for themselves. So one is the marathon metaphor, which certainly isn't original with me, but one I've stretched it's the metaphor just as far as I can. And I talk with folks about how providing care for a loved one with a chronic illness or like a mental health issue is like running a marathon, and that too often caregivers go at this as if they're running a sprint. They expend all their energy too early on, when really need to do is learn to pace themselves, and sometimes they have to really, that's a training process to learn how to pace themselves. They have to learn the uphills and downhills of the lay of the land, and the lay of the land being the disease course, how the disease is going to progress over time. They have to learn how to replenish themselves along the way. Caregivers need to grab every water bottle that's offered to them at every water station, and not say, "No, thank you, I'm not thirsty," and keep on running. And all these supports, all these different strategies for running a marathon are the strategies that caregivers need to use in order to run the very best race that they can. Next slide, please. Another idea I've used with caregivers to help them accept help is to not offer them advice prematurely. In other words, if someone comes into my office, they look terrible, they're a caregiver, and I start just handing them resources, they will never use them. Really, what I need to do before I do anything is to inquire what caregiving mean to them, what has the experience of being a caregiver meant to them in their lives. And oftentimes people share with me that they feel like they're giving back to their loved one for all that loved one did for them. Sometimes they feel like they're doing God's work in this world. Sometimes people will tell you very negative meanings, that they feel that they're trapped and this is punishment for having been a bad person. I think that when we especially when people have positive meanings for the caregiving that they're doing, what we want to do is help them. I think watching is a wonderful thing. I want to help. I want to have that sense of mission that you have about what you're doing, and then I want to help you do more of it for as long as you choose to do it. And only then that I would bring up the issue of sustainability. I would say to them, "You're running a marathon. How is it that you're going to run this marathon in a sustainable way as possible, so that you really do get from the beginning to the end the way you would like to?" And it's only at that point that very often caregivers themselves begin to talk about what are the sources of sustenance in their lives, and it's only at that point that they're really amenable to accepting suggestions for things like caregiver support groups or adult daycare programs, etc. Next slide, please. And an idea which I found helpful is to really talk with caregivers about how receiving care from others is in fact sometimes a way of giving to others. And I think about this especially when I work with older Americans who may not want to involve their children in the care of someone who's ill. And so, if let's say a husband's taking care of a wife with severe depression, the husband says, "I'm not going to ask my adult children to get involved in this because I don't want to burden them. They have their own life." Then I'm very quick to say to them, but if you ask your children to get involved, in fact, you are giving them the opportunity to step into an adult role to really make a difference in your life and the lives of their mother, and that you are, in fact, giving them an opportunity to mature. And with that argument, sometimes those caregivers are more readily accept help from other family members. Next slide, please. I want to now turn specifically to talking about kids who may mental health care. And want to hasten to add that the majority of caregivers will never need formal mental health services. So the question then becomes, who does? And so it's caregivers who are so depressed, so anxious, so angry, and perhaps so guilty that it's really affecting their capacity to function effectively as caregivers and function effectively in other years of life. Really, the for who gets the mental health referral is the issue of severity. Those who are most severely affected get mental health referrals. Next slide, please. The term that you have probably heard a lot is caregiver burnout. So I just want to define that very briefly. It's a sense of dread or tension, irritability. People who wake up feeling like, my God, I got to do this today. I don't want to do this today, and often have disturbed sleep and some concentration difficulties. And caregiver burnout is often a precursor to clinical depression, or what we call major depressive disorder. In the case of my patient Don, he came in very anxious and was distracted and jumpy, had the fragmented sleep. I mean, he'd be the sort of person I'd be thinking about, does he meet the criteria for major depressive disorder? Next slide, please. So we talk about major depressive disorder. There are specific criteria as part of the DSM-IV, as I'm sure you know, but they involve things like sadness or lack of capacity for enjoyment, sleep and appetite disturbances, and so it's with the criteria that we make the diagnosis. And what we know about major depression is that it's not it's a disabling condition. It's an illness for which people need treatment, and the best treatments we have are psychotherapy and as well as medications. Next, please. A very common disorder which we see some caregivers suffering is severe anxiety, most often of the generalized anxiety disorder type, where the person, the caregiver, just is worrying persistently and doesn't have the ability to control their worrying. They may be very tense, and they're often having sleep disturbance. And again, the or psychotherapy and medications. Slide, please. Who we refer these folks to? We identify them. I think it would be very important to refer to folks who understand a little bit about the stresses that family caregivers endure, and as well as therapists who are medically knowledgeable. We want somebody who understands some of what the care recipient's condition is, and not simply what the caregiver's mental state is. So a good resource for that is the APA Psychologist Locator. If the caregiver is reluctant to go to a mental health provider, I would urge you to suggest that they go to their primary care doctor and have a discussion with a doctor. The doctor is qualified to diagnose them and not give them ongoing psychotherapy, but certainly to prescribe medication. Yes, the most important point here again is we want to help people see accept mental health care as a way of strengthening themselves, as a way of running a better race, so that they can provide the care to their loved one that they want to provide, and not burn out in the process, and not suffer unduly in the process. So that is the end of my presentation. I'd like to turn it over now to Dr. David Kuhn.
Thank you, Ben and Craig. I really appreciate the opportunity to speak today a little bit about what we know in terms of caregiver interventions for older adults. And on the next slide, before I really dive into interventions, I would like to reinforce the case for caregiving as a national public health priority. Clearly, caregiving and caregivers play a unique and valuable role in our society. We know that the number of caregivers is going to continue to grow, and as it's grown, it's gained national attention. The national adoption of public health priorities is really guided by specific principles, and those principles include large burden, may act with respect to health care cost or consequences. And both of these have really been reinforced by Greg and Barry's presentations. And then there's also the potential for prevention. Now, when people often show up at our door, they're often already distressed, already upset, and maybe we haven't already prevented that, but definitely we know that there are ways to help alleviate and prevent that from getting worse, and we can definitely do that across the care trajectory. And I think there are also other ways that need to be explored to help really on the very front end that hasn't been done, and I'll talk more about that in a minute. On the next slide, I think it's also important to raise that caregiving really is a health disparity. These folks are our hidden patients. They're rarely assessed for their own health issues and needs. It's usually all focused on the care recipient. They often come with multiple roles. It's not as if people just show up to be a caregiver. They are workers, they are grandparents, they are all different types of people. They lack energy or time for health promoting strategies for themselves, and when we look at comparisons between caregivers and non-caregivers, we see significant gaps in terms of the quality of our caregivers' health. It's important to recognize that disparities exist across groups of caregivers as well. There are differences in terms of how people experience caregiving by race and ethnicity, the impact in terms of gender, and differences in terms of spousal versus adult child as well as other categories. And all this, I think, really highlights the need for caregiver interventions and ongoing work in the development and testing and translation of caregiving intervention work. With regard to informal caregiving for family and friends, older adults that are facing behavioral health or mental health issues, unfortunately, the vast majority of intervention work today really has focused on Alzheimer's disease and related dementias. And I'm going to use that as a backdrop. Clearly, we need more work with other mental health issues, but I hope that you can take what I'm going to talk about today and begin to think about how that might also be applied into other behavioral health concerns. So as we look at the next slide in terms of the chronic stress trajectory of caregiving, if you look at across the top and we look at the caregiver or care recipient trajectory, we know that there is a period where people begin to initiate IADLs, helping with finances, helping with navigating transportation issues or medical appointments or whatever it may be, and then an expanding role where those activities may grow, as well as activities of daily living and helping make sure that people are fed and clothed properly, etc. And then there is a trajectory where some people may be placed at some point along the way into an institution or assisted living facility or group home, and then there is the death of the care recipient, and that may or may that trajectory of placement may not always occur in all family situations. When we begin to move back in terms of looking at initiating IADL and caregiving activities, we know very little about the beginning in terms of the impact of interventions. The vast majority of interventions really haven't focused here. And is that psychological appraisal benign? Are the health effects minor? And so we do know with some of the work that's been done that's really targeting these kind of dyads or families, that most of the work has really looked at the impact of interventions on the care recipient. There are some of us, like Carol Whitlatch at Benjamin Rose Institute and Steve Zierett, and myself, who've begun to sees this as an opportunity to figure out how we engage in families and family caregivers together early in the process to help prevent stress in the future. My next part of my talk is really going to focus on this next stage of the expanding IADLs and ADLs, where the level of distress that was talked about, the psychiatric and physical morbidity, and even there has been studies that have demonstrated that stressed caregivers may actually die faster. That's where most of the caregiving intervention research has occurred to date. So on the next slide, what is successful in terms of implementing caregiver interventions? What do we know to date? And this overall categorization is one I utilize in a variety of my work, and it's there are similar categories that appear in other people's work. And our findings are in line with meta-analyses, that is, grouping together the results of large numbers of studies and seeing what the impact. But we actually have used the American Psychological Association criteria to help evaluate what are well-controlled, well-done studies or trials, and helping us determine what has had the best impact on caregiver distress in terms of things like depression, anxiety, and anger. And what I'm about to say doesn't always make me popular. If you look at the top and you look at the darkest four at the top of your slide, education, care management, respite, and support groups, these are what are actually most available out there in the community, but unfortunately it's what we have the least evidence in terms of supporting their impact on helping with caregiver distress. The next two, environmental and technological. Environmental and going into homes or environments and reducing the environmental press. Imagine, for example, a person has a lot of material stacked around. There's some noise in the environment. How do we reduce that has a negative impact on our loved one, as well as increase the supports and reduce the stress for the caregiver? There are technological interventions, and I'm beginning to move away from that as a category because those technologies, whether it's the telephone, it's web, it's applications, it's computer-based technologies of different kinds, they're still going to be married in some capacity with education or some kind of skill development or support. Now, the three categories at the bottom, psychotherapy, counseling, psychoeducational skill training, and multicomponent, are what I'm going to focus on next because those are actually the three categories that there's the most evidence to demonstrate that they have an impact on caregiver distress. Now, before I leave this slide, please let me reinforce, I am not in any way saying I don't believe in education, I don't believe in care management, I don't believe in the importance of respite or support group. We just need to figure out how do we help enhance or get better outcomes out of there, and perhaps they need to be married in some capacity with other types of strategies, and we'll see some of that in the slides to come. So the first category on the next slide is psychotherapy counseling. And as Barry mentioned, we know that this can be effective. There's evidence in particular for cognitive behavioral approaches to reduce depression and anxiety, where caregivers are taught how to monitor and change their thinking and behavior. Caregivers in this situation are typically screened for higher or greater levels of psychiatric morbidity, and therefore the interventions themselves are a bit more intensive, typically offered either individually or in groups across 8 to 20 sessions. Within these, there tends to be more emphasis on the development and use of the therapeutic relationship than there is in psychoeducational skill building, and on average these therapists or interventionists tend to have advanced degrees. We definitely need additional studies in this arena. There's some preliminary evidence for brief psychodynamic approaches, particularly as changes begin to occur in the care recipient that lead to grief and loss reactions in the caregiver. Slide. Psychoeducational skill training. This is the largest category. This is the category that we have the most evidence for. And there's a variety of interventions here that focus on different distress targets, such as depression management, anger management, care recipient behavior management. These typically emphasize skill building, teaching coping skills on how to manage the emotional or behavioral problems, and the target can be the care recipient, the caregiver, or both. These also are coupled with basic support and education in terms of particularly about caregiving issues or the disease, for example, Alzheimer's disease or related dementia, but it is not done at the level that you'll see in a multi-component intervention. Now, examples of these include Ken Hepburn and Oswald's Savvy Caregiver Program, Kathleen Buckwalter and Jerry Hall's Progressively Lowered Stress Threshold Model, and Dolores Gallagher-Thompson and my Coping with Caregiving project. And so just to name a few, I am going to move on to the next slide. In this next slide, there is, I wanted to use this as an example of how the Alzheimer's Disease Supported Services Program, supported by the AOA, has supported evidence-based and innovation projects for family caregivers. And you can see that there are, with the moons and the stars and the suns across a variety of states, it's an opportunity for organizations within states to translate programs and embed them into the community. And I'm going to talk a little bit about our translation of coping with caregiving, but this map also relates to two other interventions that I'm going to bring up later, two multi-component interventions. So on the next slide, the coping with caregiving. And when I moved to Arizona, I took feedback from our community partners as well as past participants and pilot participants to begin to tailor more for organizations the Coping with Caregiving project. And we began to, instead of having all group, we began to alternate skill building groups with coach calls that tend to reinforce on an individual basis over the telephone the kinds of skills that people were learning in their classes. And again, this builds on the mood management, stress management, communication, problem solving, behavior management kinds of activities that were in coping with caregiving and targeting the outcomes that we saw, where we reduced depression, reduced negative coping, avoidance coping, increased use of alcohol, smoking, etc., as well as reducing negative social interactions and enhancing positive coping strategies like problem solving. These grants and projects really help build partnerships. So I have partners listed there, but what I think is really important to reinforce is that the two Alzheimer's Association chapters across the states of Arizona and Nevada then took this and we trained them and embedded and moved it into their programming of their chapters in relationship with the area agencies to assist with respite when needed by these family members to attend the group sessions. We're still in the middle of this project. We have outcomes coming in the summer, but overall the benefits that people are reporting are quite high, with over 95% reporting significant benefits. I want to then talk a little bit about multi-component interventions, where we incorporate two or more, and that's the next slide, incorporate two or more conceptually different approaches into an intervention package. There were only 3 projects as we reviewed the literature that really met this category, and thus we need to warrant, it warrants replication of these to this, as well as looking at other options about how to build these. And 2 of these 3 are being translated as part of the AOA's ADSSP evidence-based projects that I mentioned, and that's the New York Caregiver Intervention as well as the REACH2 project. So on the next slide, if I could just speak to a moment to the NYU Caregiver Intervention, this enhanced counseling and support intervention really has 3 overarching components: 2 individual and 4 family counseling sessions that teach caregivers ways to manage the patient's behaviors and or promote family communication. It also provides education and links to community resources. The second component is an ongoing support group for emotional support and education, and then the third is an ad hoc counseling component to help manage crises and various changes and transitions that occur over time. The NYU Caregiver Intervention demonstrated its ability to reduce caregiver depressive symptoms. It's the only study with really longer-term follow-up. It has well over 3 years of follow-up, and found an impact not only on reducing depression, but also on reducing nursing home placement. On the next slide, the REACH2 intervention was built from the initial REACH project that took components, from 6 different REACH sites, and we took these components, like components from Coping with Caregiving, and then created a multi-component package. So this multi-component in-home individual intervention, so as opposed to a group-based intervention, it's primarily individually individual intervention that involves education and skill training. However, it's also combined with a telephone support group as well as what's a computer telephone integrated system that allowed people to connect on the support group, allowed rapid dialing or connection to resources in the community, and the ability to create respite functions for the person that was living in the home with the caregiver. It addressed 5 key areas that are linked to a caregiver risk profile, and we used that risk profile to target particular caregiver concerns and related distresses. And you see the 5 different areas listed there, ranging from safety and social support to care recipient behavior problems, the emotional well-being of the caregiver, and self-care and health behaviors. Now, I think it's important to let you know that this particular intervention is one that had 3 different ethnic and racial groups, and we need to really enhance our work in caregiver interventions in terms of diversity, but this targeted Hispanic, non-Hispanic, white, and African American caregivers, and on a quality of life outcome indicator that incorporated depression, burden, social support, self-care, and problem behaviors of the care recipient. We saw reduction for Hispanic and non-Hispanic caregivers, showing greater improvement in these areas. And it was also true for African American spousal caregivers, but not for non-spousal, which again raises the issue that I think there's still more work to do. If we return on the next slide to the chronic stress trajectory of caregiving, just to reinforce in your mind where we are, knowing not that much about initiating, but where I've just gone over is the vast majority of caregiving intervention research has happened at these more extended levels of care recipient need. On the next slide, I'd like to talk a little bit about placement, and I'm going to use data that came from the initial REACH project, where we recruited over 1,200 family caregivers across the 6 sites, and REACH followed caregivers and care recipients across 18 months, and some of those care recipients were placed during that time period. And it won't come as a surprise to people that work with family caregivers that caregiving doesn't end with placement. There was no significant change before or after placement in terms of depressive symptoms or anxiety, and I think it's interesting to note that depression was higher for caregivers who were married to the care recipient, visited more frequently, or were less satisfied with the help received from others. In recent qualitative work that I'm doing, I think I've gotten a window in and looking at people that have placed their loved ones as well as staff working with them, that for spouses, there's an incredible amount of loneliness as the person is placed because they're often living alone in a house. And so I think that might be a picture that helps us understand a little bit more about what's going on here with placement. Anxiety results were similar. On the next slide, I want to just touch on a little bit we know about caregiver responses after care recipient death. And I think it may be surprising to see the impact of interventions here. And this is drawn from the original REACH project, because the REACH 2 project only followed people for 6 months, and again, the original REACH project followed people for 18 months. But we've seen that REACH, there were significant declines in depressive symptoms after the death of the care recipient, that is within 3 months, and these fell substantially below caregiving levels at 12 months. What I think is interesting to note that involvement in one of the psychosocial interventions that have been happening at the REACH sites, like the coping with caregiving intervention, had an impact on whether or not the caregiver experienced complicated grief. Similarly, in the NYU Caregiver Intervention, intervention participants reported fewer depressive symptoms after bereavement than those that were in a control condition. So if we look at the next slide, I filled out a little bit across the chronic stress trajectory in caregiving, that as we move into placement, there still is distress for the caregiver, continued depression and anxiety, and the need for re-engagement with others outside their caregiving responsibility. And at death of the loved one, there is relief and recovery for the vast majority after that. In closing, I just want to look at the next couple of slides here. The first one, for a plan that's specifically targeting people facing caring for somebody with other types of behavioral health or mental health concerns, there is the family-to-family program. It's a highly structured course that many of you may be familiar with that lasts 2 to 3 hours a session for 12 weeks, and it's offered by NAMI-trained family members. It has an education component, a problem-solving and advocacy skills component, self-care and mutual assistance coaching, and that there has been in a recent trial evidence for improved problem-focused coping for people that participate in this, as well as knowledge about mental illness. Unfortunately, they did not find reductions in caregiver burden or distress, and moreover, the average age of these family caregivers was 52, and 60% were parents caring for someone who was younger. So this highlights the need for future work in this area, using something like family-to-family or drawing from what can we learn from the skill training and multi-component interventions that have been tried to date to apply them to other types of mental health and behavioral health concerns faced by older adults. What can we do for those caregivers in terms of changing, offering, or repackaging interventions? On the final slide that I have and that I'm going to talk about, I really encourage a call for multiple levels of intervention. Most of our interventions really focus at the individual or interpersonal level, ranging from information and referral helpline to skill-building groups and psychotherapy, as I've discussed, or interpersonal types of interventions like programs, early-stage individuals or spouses that are caring for someone. But we need to look at what are organizational or systems change interventions that could be married with these. How can healthcare organizations and community-based organizations create care pathway partnerships that would be useful? We know there's still a struggle about handoff among us. At a community level, what about media campaigns, interventions within continuous care retirement communities, the Village Network, for example? And at the policy level, there's the National Family Caregiver Support Dollars. The AMA 10 or so years ago really encouraged a caregiver self-assess tool. Barry mentioned the ones that are on the FCA website, etc. And we in Arizona and other states are really looking at respite tools to help assess the caregiver in addition to the care recipient when allocating respite opportunities. And all of these represent, in my opinion, depending on where they're embedded, shifts in policy. So finally, I've provided a series of slides that will be available that are references that include some books, the research articles I cited, and then the first link is actually a link to the ADSSP programs I mentioned. And so those are there for you to review afterwards. But now I would like to turn it over to Dr. Sarah Hahn-Qualls, who's going to discuss complicated issues in working with family caregivers.
I'm delighted to join you today also. Ned will provide for you the cues I'm going to talk about today. I'm going to step back now to sort of a clinical vantage point here and talk about 3 complicating issues. How do you decide where to focus when caregivers bring you many, many problems in complicated situations? How do you help families navigate their interface with service systems? And then how do you deal with interpersonal conflicts within the family? So first, on the next slide, think about where you begin. I need to recognize that families don't use our language. As mentioned earlier, they may not think of themselves as caregivers. They're some families doing what families do. So they're not using our language. They're not often using medical language or social service language familiar to us from the settings that we work in. Our opportunity for engagement is brief. They tell a story, they give us a concern, and we have a moment in which to use that as the lens in which to enter a wide range of concerns they have. I want us to consider the context of our encounters with the caregiver. What's realistic for that moment that we have and the context that we're in? And I urge people to really listen for the focus of the story. Is it on the caregiver, him or herself, and about distress that person's experiencing, or the caregiver discussing the care recipient and concerns about how to get access services or move that person through the care system? Are there decisions pending? Or focus even on cost to other family members. So the general idea is to try to build an alliance over the purpose and mission that this caregiver feels at this moment in time, in this context, to share with them in the brief moment that we have. Next. A large issue, I think, for caregivers is that it is really challenging for them to interface with service systems. Most of us at a point in our family development don't know about the next stage of family development and all the resources relevant to it. We figure it out on a need-to-know basis. So caregivers of persons with mental illness, or substance abuse issues, or health issues of any kind really discover the service systems right when they're in the moment of greatest need. They come to that moment with a different language, often a different frame, and considerable ignorance of the systems they're entering, so inevitably they get frustrated, and often the service system can get frustrated with them as well. So there can end up being mutual blame and disconnection and even more stress for everyone involved, just in the very process of trying to engage in getting services. Next. Questions are very practical. They get into these systems with very practical questions. When should I be worried? Do I know that this is the moment to step in? How do I know? How can I know what's really going on at home when I'm not there? How much risk is there? Yes, she's tottery, or yes, he's exploding more often in anger, but how much risk is there really? I'm overwhelmed. My family members and I who are sharing this care disagree vehemently about what needs to happen. What do we do about that? How do we handle that disagreement? Next. Although the family questions are practical, there often then ends up being this big disconnect between the family seeking and what the service system is providing. So in this particular slide, we're thinking about the health system. The family may ask the questions, why won't you talk to me? I'm not supposed to take care of her. Or when they tell me about all the options, they just told me the one option they had. Or they think a lot more control over this person than I do. On the health system, maybe circulating statements behind the scenes of we can't talk to the family. This is the parent who's in charge of his or her life. If the family were involved in a better way, she wouldn't be struggling so much. Or let's do our job. Why do they keep meddling? We're just trying to take care of this person as best we can. But he needs to take more charge, or else this person will never get his feet on the ground. They have to make him take his medicine. Disconnect on the next slide could be illustrated then in the housing systems, and I'm just using this as an illustration. The family experiences all kinds of challenges in that system because intermittently where she may be living and seeing, for example, she's sitting for hours, or in this setting she's a bath or a feeding or a capitated payment. Resent me for being there. How come if you know what's going on? I'll hospitalize her or change her treatment plan. I had no idea this was coming. And housing providers may be family want us to care for their loved one as if it was the only person that we have, but with a lot of clients. Why can't we do our job? It's mine to take care of. They asked me to. Or the family come in because I know they're going to find something wrong to yell about. Connects on the next slide. Different languages, different vantage points, and I think often our work with caregivers can benefit from us coaching the caregivers to navigate these systems. We know for professionals that the service systems are complex and require support for successful navigation. Certainly the families are going to need some help. Most multiple points of entry. There's not an obvious treatment point. Once at whatever that point of entry is that one finds, there's often a lack of a clear pathway through. And no provider owns the problem. When the day is done, the family owns the problem. 5 o'clock on Friday with the discharge, the family's supposed to find the solution. And so they don't always understand that the providers are defining their roles fairly specifically, whereas the families view their roles as broader. That leads to some real disconnect if the family isn't coached in how to work their way through the system. Next. To our best of our ability, it helps if we can make service user-friendly, using language, really offering very clear pathways to help. Tell people the location and what to expect from the service, giving them as specific contact information as we can. Making what won't be there at that next service step in the way the family member might hope it will. And offer family the option to return if they lose their way in that process. For success with the care recipient in systems. Caregivers are often, again, very focused on practical. Well, he's going to go to the doctor or take her medicine. There's no way she's going to go to that service. So I think it's very helpful we can focus on both what they need to do and coach them on how to do it. Next. The third point I want to talk about a little bit is when we've got interpersonal caregiving conflict. Often when I have more than one person in the room, and when that happens, it's very common that people have different ideas about what ought to happen for the care recipient. And I've learned to start with some values clarification. What do you want most for the care recipient? I have a family member to say what they're thinking about what is really important to them for their recipient. And I listen carefully for the almost universal dilemma that family members end up expressing, a desire for both independence and safety as guides that in individual after individual after individual. I can then summarize that, what we all heard, by the ambivalence that we all, meaning two valences. We both feel strongly that we want our loved ones to be independent and we want them to be safe. And that's true across the lifespan in families. When particular family members have become the voices for one side or the other. One family member is quick to notice when independence might be condemned in some way, whereas another family member is quick to notice when safety might be at risk. But may come out within the family as you just don't care or you're always trying to take control. I know as simply the voices that these particular family members have developed that are experts for one side of that ambivalence or the other. We all share both sides. So I welcome you to comment when your voice of expertise is ready in family. It kind of depathologizes that conflict a little bit and moves it away from being between people to reflecting the ambivalence each person feels and is expressed with particular insight or intensity by one person. Next. Keeping in mind that the families that we work with often have a very long history, the relationships are decades old, literally, and often seeing the dynamics that were in place, especially between siblings, at the time that they left home. That was the time they were really together. So they have not probably done a significant problem solving together that was more expensive than planning a holiday event since that time. Given that personalities are relatively stable, they cue each other for those old dynamics. It's very easy for them to go back into them and make statements like "you always" or "even when we were kids," da-da-da-da-da. And our work wants to focus not on the 20 or 30 or 40-year-old conflicts typically. We're focused in the here and now. So on the next slide, I work on really helping the family get focused in on what is the challenge of this moment, recognizing that whatever the caregiving challenge of the moment is, it sits smack dab at the intersection of individuals' developmental trajectories. They have their own things going on. The stressors and opportunities of this moment throughout lives, including caregiving, and then the family development that each person is in. A daughter or son of an aging care recipient might also be launching adult children. A parent of a 21-year-old exiting a disability system and going into a school system and going into the adult disability system has other things going on in his or her life besides caregiving. Next. When I work with caregivers, I try to end my intervention episode, and I think of it as episodes of intervention because they often need to cycle back through when the next stressor occurs, by inviting them to really widen their lens, to think about how caregiving and the approach that they've taken today, the problem solving that we've done together, usually has resulted in some sort of a role structure. So how does that role structure fit within the other roles of the caregiver's life? I help them really think about mapping out the caregiving structures within the family as a whole. Who's doing what and whose roles fit where? And look at the broader impact of those structures on all the family members. So on the caregiver-care recipient dyad, how does this caregiving structure influence other family members? What we don't want to do is to set up a caregiving structure that the caregiver can implement successfully at great cost to the teenagers in the family, or other elders in the family, or other care recipients. Pausing to sort of think for a moment through this wider lens whose development might be at risk from this caregiving structure and the way they put it together can be really productive to head off some problems that could arise otherwise. Next. So I'm always looking for the smallest change in a family that will make a difference. Sometimes we need to teach comprehensive skills, sometimes we need to plug in respite, sometimes we need to give education. In connected families, what is that the squeeze wheel will end up taking a good bit of our time. Sort of the 20 rule applies here too. 20% of the families will dominate our clinical practice or our service delivery system because they are long-term messy families or they're filled with personality disorders. So it helps me just to get grounded, to come back to moving in small steps. What can I do? Sometimes thinking strategically, again, the smallest change that can make a difference. Next. Last thing I'm going to comment about is the development of the family caregiver briefcase. It was mentioned earlier, actually Barry Jacobs and I both were on the task force that developed this briefcase. It is a very rich resource that rides on the website of the American Psychological Association, and you can see the app there. It provides all kinds of background information on facts and strategies and summarizes the research, provides some suggestions about practical issues. If you're a mental health provider, how do you bill for this? What can't you do? What are some unique ethical issues that arise? What are some advocacy resources, etc.? So I just invite you to use that resource as it's useful to you. And to turn this back to Greg Link to tie the together. Thank you.
Thank you also to Barry and David for all of the great information that each of your presentations contain. I think everyone on this webinar can agree that we're dealing with a very multifaceted and complex issue. And I also think it's safe to say that because we likely need multifaceted, very flexible, very person-centered approaches as we explore the best possible ways for addressing family caregiver needs no matter what their situation. And I think we learned today about a number of very well-tested, well-developed interventions and how those could be adapted and applied to caregivers of individuals with behavioral health issues. But I also think we know that we know of good interventions and approaches that likely need some additional research and focus. Before I open the lines for questions, I just wanted to talk for a couple of minutes on the next slide about the current family caregiver support landscape in the U.S. I know that we have a lot of folks on the line listening, many of whom work in the behavioral health system, many of whom work in the aging network, whether it's at the state level or the local provider or area agency level, and there may also be other professionals listening in who have an interest in this as well. And I'd like to use this time to help everyone hopefully think about some of the partnership opportunities that are out there and available to them. And currently, a number of federal programs that support the caregivers in some way. We've mentioned, I've heard a couple of folks in the National Family Caregiver Support Program. It has a very programmatic way of supporting family caregivers through a menu of services, and I'll talk a little bit about that in just a couple of minutes. We also have direct service programs and services available like respite through multiple funding streams that may be of some definite benefit to family caregivers as part of their overall approach to supporting their needs. And then we have some specific programs built around conditions such as Alzheimer's and dementia, like the Alzheimer's Disease Supportive Services program that Dr. Kuhn talked about. And then, as we all know, many states have their own discrete programs that be likely partners in meeting the overall support needs of family caregivers. Next slide, please. I want to talk for a quick second about the National Family Caregiver Support Program. For those of you who may not be familiar with it, it is a program that's available in every state and territory. It was created as part of the 2000 reauthorization of the Older Americans Act. It contains two components, the Title IIIe program of the Older Americans Act, as well as the Native American Caregiver Support Program. And in 2006, the Older Americans Act was reauthorized, and the National Family Caregiver Support Program was modified a little bit to expand some of the age groups and categories of individuals that could be served. Also, it refined the targeting criteria. Next slide, please. A few things to know about the National Family Caregiver Support Program is that it focuses on the family member, the family caregiver, as the service recipient. And the Caregiver program had its genesis in work done previously in a number of states to support family caregivers. It's a package of 5 services that have been demonstrated to be of most use and value to family caregivers. And I think most important is that it's integrated within the structure of the Aging Services Network, the states on aging, the area agencies on aging, and the provider networks. And it's with that network and within that structure that I think we have the opportunity for partnerships across behavioral health programs and across other service programs to best meet the needs of family caregivers. Next slide. I've put just the required services that are available under the National Family Caregiver Support Programs. I think we have a lot of opportunity within the counseling, support group, and training service category for 3 or National Family Caregiver Support Programs to look for tapping into some of the great work that has been done with Alzheimer's disease supportive services and with some of the other behavioral health interventions that may be in existence for exploring ways to better serve family caregivers. I leave this slide as the last one where we talk about some of the partnership opportunities that could exist between the Aging Network and the Behavioral Health Network. We have our state units on aging, our AAAs, and our local service providers. But I think there are also some tremendous opportunities for mental health service programs and providers to partner with caregiver support programs, with state caregiver coalitions, with local caregiver coalitions, and the respite coalitions, as well as exploring with these programs best ways to develop support group options, implement training programs for family caregivers and the care recipients, as well as education opportunities. So I want to thank everyone for your attention to the webinar. I want to move now to the question and answer portion of this webinar for the time that we have left. You can type your questions into the chat box feature, and then our host will select the questions and read them, and then the presenters will have the opportunity to respond.
Thank you, Greg. Our first question is about meditation. And do the presenters have any comments on meditation as an intervention, like the mindfulness-based stress reduction or mindfulness-based cognitive therapy? Those interventions is growing rapidly, but do you have any additional comments on these interventions that you'd like to share? The presenters can respond.
Sure. This is Kuhn. I guess the one comment I would make is that there are a number of programs that have incorporated mindfulness as part of stress reduction, not necessarily the exact approach that you're talking about. There's been some evidence of people using meditative work along with yoga to help reduce stress. I mean, I think that there's an opportunity for here, and there's been some preliminary work, but I haven't seen the kind of same level that we were using to compare things, that I was using to compare things. So, and I know Barry and Sarah may have comments as well.
So this, I think that the medicine in general, as David says, is excellent for stress reduction. I think that certain meditations which aim at what's called non-reactive awareness is a very important skill for caregivers to have, to be able to observe the care recipient and interact with them in an interesting way, but in an overly reactive way, that allows caregivers to really conserve their energies and function more effectively. And I think meditation helps foster that.
Thank you. Our next question is, what do you think about a centralized caregiver support through a specialization certification that would bring folks to either work directly with families and informal caregivers, or become activists in their communities and create evidence-based programs? So just comments about that.
This is Greg. I think that's an interesting concept, and one that may be worth exploring a bit more. So I think any method that we can use to reach out to family caregivers, to inform and educate them about the fact that they are what they are doing is caregiving, that they're likely to become stressed and would likely benefit from some type of intervention. I think would be a great idea. I also think that it takes some special training to effectively work with family caregivers in any number of situations.
Thank you. Our next question is, I work in a rural state, South Dakota. Do you have any comments on providing caregiver support, such as respite, education, etc., in rural and frontier areas of the country?
Well, this is Greg. I can speak from the experience that we've had in implementing the Lifespan Respite Care Program, and the whole function of that program is to increase the availability of respite care services, and it can be done in any number of ways. And we have a number of rural states who have used their Lifespan Respite Care grants to develop voucher programs and other consumer-directed options for respite services, whether it's paying neighbors or friends or other family members who may live close by to provide that respite care, or exploring the possibility of developing volunteer sources through faith-based community and other community service organizations as of respite care. A couple of the states that I've worked with have also worked closely with their university systems as a volunteer source of respite. Students who are completing human services degrees, who may have a volunteer requirement for their degree, they've actually been trained as respite care providers in certain situations, and they fulfill their volunteer requirement for their degree, and they're able to provide respite, and and they learn a skill as well. So there are a number of options. I'd be happy to talk with you more about where you can find more information about that.
Okay, go, Sarah.
I was going to say, I think that the idea of looking for places where people are already receiving services is really key. So Barry Jacobs emphasizes primary care. Greg just mentioned faith-based communities, Stephen's ministry type programs. There are a lot of indigenous people providing support to family members who are caregivers. And we can those folks and get some training to them. They can do respite, but they can also provide some degree of peer counseling and support, education, navigation support as well.
I guess I would say that we have successfully, or the chapters have successfully navigated, if you're not aware about Arizona, but we have large rural areas, and we have, as Sarah did, identified places that the chapter can house or have meetings in partnership with other organizations in the community. It does require, for example, if you're going to have face-to-face group, that for X number of those people come in, but it's why we took feedback to have a group telephone individual coaching mixture was for this. It also, it's interesting when I hear this about doing intervention, it also relates to people that, in a sense, are homebound even in urban areas. There are growing numbers of web-based programs, DVD programs that are based off of evidence-based programs to help reach people that have difficulty getting out of their home. The flip side is we've also talked sometimes in rural areas that sometimes that can be we want people to get out and engage because part of their challenge is staying in the home. But it means having that combination that Greg mentioned of consumer-driven. Is there another family member or another friend perhaps in that area that could do the respite depending upon how it works within that system, et cetera. So for those group meetings, the person's able to come. Or, as Sarah mentioned, is there an area that they can come to that the care recipient can be cared for while they participate? So it's working all of those out that have seen different models work, I would say.
Our next question is, can presenters comment on caregiving and grief? Some of the caregivers that I work with are palliative care clients, and grief on top of stress is often the case.
So I certainly see this an awful lot. I think seeing a loved one declining in general is grief-provoking, and very frequently caregivers who are struggling are struggling emotionally to accept that their loved one is going downhill and perhaps dying. I think your point is well taken. I think that as part of the way we support caregivers, we need to help identify grief for them, normalize it, and help them come to terms with what's happening. What I like about hospice services is that they're dealing with anticipatory grief, and then very frequently providing bereavement counseling, their loved one's death. And in my work with caregivers, I often work with them, up to a year after the care recipient dies, just to help them grieve, generally, but also specifically to really come to an appreciation of all the work that they did, and not blame themselves for the care recipient's death, or somehow feel that as caregivers they didn't do all that they could.
I will comment that another question I see in the chat box is about the difference between spousal caregivers and adult child caregivers. I think that the grieving process is quite different, and a lot of it is because you're something very different. And so it reminds me to focus on not only the loss of the person, also to pay attention to the loss of the life structure. Spouses who are caregivers are losing a lot of life structure as they the relationship is changing in very significant ways due to the illness of the recipient. Children are losing a parent or a person of another generation, and it may or may not affect their life structure. Their daily life may not be affected as much as the spousal caregiver. So paying attention to what the grief is more than just the person. It's lifestyle often.
Well, and I would add on to that, I think it's interesting that we know from different cultural groups that how grief, it seems to that there are some folks that grieve along the way if there is a progressive kind of illness going on, others that tend to do it all at the end, and there's others that do it in a variety of different ways. So I think just touched on this, that there was evidence in the REACH projects as well as in the NYU that participation in some kind of psychosocial intervention helped reduce depressive symptoms afterwards help to do to prevent complicated bereavement or grief. We need to better study that to understand what are those components that then we can help better present to folks who are doing the very work of the individual that asked the question. How do we better provide something that would make this clearer for folks through that process?
Is there any prevalence data on caregiver death rates? That is, caregivers who passed away before the care recipient?
That's a good question. I don't have the data in front of me. I know that Rich Schultz and Scotch Beach looked at that stressed caregiver death trajectory for people that were stressed, but I'm not aware, but maybe other panelists are, in terms of good side on that. It's a pretty hard data to collect when you think about it.
Mm-hmm. Okay. And then our last... one more question, and that is, this is for Dr. Kuhn. Have more areas with less evidence of effectiveness, such as education and respite, been evaluated and found to be less effective, or is the issue that there hasn't been any real evaluation of the effectiveness of these approaches?
There have been some studies, but haven't reached the criteria that we've used. And I think there are different ways to think about it. When you think about education alone, I think all of us think about it. When somebody tells you something, if they're not kind of follow-up or ways to help coach you through how to integrate that in your life, it may be challenging for you. I think that respite, we know respite is valuable. The question is, can we marry it with something, how that person more effectively utilizes that respite time or gets additional support to help them manage whatever is happening when they don't have respite time, I think is critical. Case management, I think one of the challenges with case management is those of you that do care or case management, there's a wide variety of that, and so looking at good controlled studies that help with that. And is there an opportunity to infuse other types of activities that we're seeing working and other types of interventions into that? And support groups, it is getting a little bit blurrier, as sometimes people call something a support group, and we didn't just do what people called. We looked at what their components were. The coping with caregiving was compared directly against a support group with the same amount of duration and the same amount of time involved for caregivers, and those findings that we have were over and above what we found in support groups. And again, I think it's also looking at what line cross between providing information and support into also providing skill training or something else that may help people manage their situation more. So we need more work in this area, and I think we, again, I think we see that, for example, support groups are become married with multi-component packages and have been useful in that component package. So I think we need more work in these areas.
Okay, thank you. That was our last question, and that concludes our webinar. I want to thank everyone who logged on and participated and viewed this webinar. I hope you found the information useful, and I want to thank our speakers today for your time and for your expertise. I wanted to let folks know that this is the last webinar in the series of the Older Americans Behavioral Health series, and that for those of you who joined the webinar today, you will receive a copy of it along with a list of resources on caregiving. Many of those resources the four touched on today, you will have information about those and links directly to them. So with that, I will conclude and give a big thank you to everyone for tuning in. Thank you so much.
Goodbye.